Bismillahirrahmanirrahim. Assalamu alaikum, everybody. On behalf of Parsa HealthNet Echo Pakistan, I welcome all of you to today's session by Dr. Bilal Hameed on COVID-19 and liver. I'm expecting this to be an exciting session, and all of us are going to learn a lot from today's talk. A few announcements. Please stay muted all the time. If you have some difficulty about voice, you can switch off home or from wherever you are joining or logged in onto the same Wi-Fi, because this also slows down the reception. And Wi-Fi usage has increased during this time. All of you are aware. We will not be going through to the usual round of introduction because that will take a lot of time. We already have close to 50 participants right now. So we will not be, similarly for question and answer, you have to use the chat function. So we will be following the chat, and at the end of the talk, we will be asking the questions to Dr. Bilal Hameed, and Dr. Zishan Ali from Karachi will be asking all the question. For any queries, meanwhile, during the talk you may have, please you can send a message in the chat. We will try to sort out the problem. I welcome all of you again, and extremely thankful to Dr. Bilal Hameed, is a very dear friend, and who has always come to give talk for echo sessions at a very short notice, and this time on a holiday, and how precious it will be for all of us. And for Bilal, he's been here, and he's going to talk on COVID-19 and liver. Bilal, just start with a brief introduction, where you are working, your expertise, and then you will be sharing your talk, I guess, from your laptop. Over to you, Bilal.
Assalamualaikum everyone. Thank you, Asad, for the kind introduction and giving me the opportunity. It is a pleasure to be talking to all of you. As Asad has mentioned, my name is Bilal Hameed. I'm Associate Professor of Medicine at University of California, San Francisco. I am the Clinic Chief of Hepatology here. And when the COVID-19 started, San Francisco or California was one of the hardest hit area in America early on. So we had to make a lot of changes for our liver patients, a lot of things we are learning. And so we were talking to our society, AASLD, to come up with some insights specifically for patients with liver disease and COVID-19. And so we were started a working group, and then it was approved by the governing board. So I'm one of the author of the recently published insight guideline for AASLD. Again, I'm no expert on COVID-19, so I may not able to answer all of your questions about specific about COVID-19. I learned more than I wanted to. Now everyone wants, is getting a lot of information about. And what we wanted to present in this insight is what we know right now, and what we don't know, and how the document evolved. And this document, which is actually on the AASLD website, we're going to keep updating every week once we have new studies and new information comes up. So my goal today is on behalf of AASLD and myself to talk about what we have learned and what we need to know more about. And it will be a very open discussion, because there are a lot of things that we may learn from you, what you are seeing in Pakistan. So with that, I'm going to start my talk. So as Asad has mentioned, there are some etiquettes of the Zoom meeting, and please mute yourself when not speaking. If you have any question, you can just put it at the chat on this session. If your speed of internet is slow, the quality, please switch off your video, unmute and if you have any problem, just log back in. Be respectful of everyone, whether you are asking a question or on the chat. So what was the rationale? Why AASLD wanted to come up with something? Because with COVID-19, what we know that there is a potential for direct infection of the liver. We are seeing, or the reports from China and Italy, that the ALT and AST elevation has been seen pretty commonly with this infection. There are hepatotoxic therapies that are out there for the experimental treatment of COVID-19. There is a unique potential susceptibility in chronic liver disease patient, what to do in our post-transplant patient or patients who have autoimmune hepatitis. And there's a lot of questions that we were getting on these, like what should we do with COVID-19, whether they have it or they're suspected of it. And in America, the huge issue is liver transplantation, because what do? We should do transplantation or not, how to manage them. So we needed a guidance for the providers. So that's where the background of this document comes in. As we talked about, there is an AASLD working group. I'm honored to be part of it and wrote, and we are, as I mentioned, that will be also published. But go to the website if you have questions. There is a good, I would also say that there is a very healthy discussion forum, so that if you learn something on your patients, please share with us on the website, and there are experts there. So we have to learn from each other, because this is a pandemic, as we know, and we need to learn more about it. So my goal is today is mention about what is the effect of the SARS-CoV-2 on the liver, and how do we evaluate if someone with COVID-19 patient comes in and elevated biochemistries. What happens if you have a patient with liver disease or cirrhosis, hepatocellular cancer? What are we saying to them right now? If you have a patient who has a post-liver transplant, is there anything specific we need to talk about it? And specifically, a lot of questions about if your patients are on immunosuppressive agent right now, what are some of the evidence or some of the suggestion that we can have? Again, it's all will be individualized. What to do with the procedures related to the liver? I'm not going to talk about the endoscopy or PPE, what we needed to do, but just what about our liver patients? And then briefly, medical management of patients with COVID-19, what we know as of right now. So most of you are aware about the SARS-CoV-2 is a novel envelope RNA coronavirus, which was first identified in Wuhan, China. This is, we have other coronaviruses, as we know, which has caused common cold, but the two big ones that we heard about was the SARS-CoV, which was in early 2000, and then we also had this MERS, Middle Eastern Respiratory Virus. So it is similar to the SARS-CoV, and then if you have a respiratory disease or clinical syndrome, that is what we call COVID-19. Since it was diagnosed in 2019, it's called COVID-19. And it has shown to be more severe in older individuals and those with underlying medical conditions. Right now, United States is the epicenter of this COVID-19. In early studies, most of the studies which have been published right now are from China. We are finally getting some data from Italy and Spain and France, but they are not that well published right now. It's just communication. But the first study of 138 hospitalized patients from Wuhan showed that fever is very common, up to 98%, fatigue and dry cough. But then larger study, which was published in New England Medical Journal, found that, that we have early on admission, 43% patient had fever, but ultimately, not everyone, but about 88% had a fever during the hospitalization. Cough in this study was seen in 68%, then you have fatigue and sputum production. So it's not always dry cough, which was actually said in the first study. But luckily, at least from the China data from their disease percentage control, that majority of patients, up to 80%, were mild. They did not have a pneumonia or very minimal symptom. 14% of cases were severe, meaning that they have shortness of breath, they have increased respiratory rate, they have lung infiltrates, and about 4.5 or 5% were critical patient, meaning that they went into respiratory failure, they have septic shock and multi-organ failure. So despite that, it is about 80% of patients were mild, although the data from Italy is a little bit different than what we are seeing from China, and there's a lot of reasons behind it, and any expert in coronavirus or COVID-19 can explain what the differences are. But what the other thing we also know that the incubation period on average is up to 2 to 14 days or about average 4 to 5 days. So there is a lot of what we call asymptomatic carriers, which does not have any symptom, mostly children or young people, and then they can pass along to their family members, especially people with risk factors. And that's where the concern happen is that, social distances and, with the shelter, lockdown, curfew, whatever the words have been using all over the world, is to try to break that cycle. Because that is right now, without having a vaccine, without any treatment available, that is the only way to control the virus. Now, this data every time, like within hours, I updated it. It's scary that we have right now, as of this morning, 684,000 cases worldwide with 32,000 deaths. And United States right now has the highest number of cases, greater than 100,000, and which 2,200 deaths. And New York is the epicenter right now of our pandemic or, coronavirus thing. Although the data, I just got it from website, maybe there's a new data coming from Pakistan, but so far when I looked at it, there were about close to 1,600 cases in Pakistan and 14 deaths. And that's where the huge difference that there are fewer less deaths in Pakistan. But in the US, we are getting 10,000 new cases per day. So this is real, and that's what our patients of liver disease are affecting by it. And that's why we all need to understand what this virus actually does and how to manage these patients. So if you look at reports from China, that case fatality rate was highest in patients who are older. So 8% if you are 70 to 79 years of age, and if you are greater than 80 years of age, your case fatality or dying rate is 15%. Our preliminary data from CDC indicate that the case fatality is highest among individuals greater than 85 years of age, which is 10 to 27%. So from liver point of view, I think there are certain risk factors, but I'm more worried about my fatty liver population because diabetes and hypertension, beside cardiovascular and respiratory condition, have been consistently shown as risk factors. And BMI is also a risk factor, but this is the data that we are hearing it and what we are reading about right now. So in patients who have CDC has came up patients who have the risk of severity, and this is actually patients who are greater than 65 years of age, patients who live in a nursing home or long-term facility, especially in Washington State. The biggest the crisis that happened with that one nursing home where they spread, and luckily in Pakistan we don't have most of our elders or people who live with us at home, but those people are at increased risk. Other high-risk individual is patients who have chronic lung disease or moderate to severe asthma, people who have serious heart conditions. And that's where, and the other one are immunocompromised, including who are getting chemotherapy, and patients of any age, if they have severe obesity with a BMI of greater than 40, or certain underlying condition which they label as diabetes, hypertension, renal failure. And now they're coming up that our patients who have liver disease might be also at the same risk of patient with renal failure. So that's why our group of patients I consider in a higher risk group. So now, what is the effect of SARS-CoV-2 on the liver, and how do we evaluate a patient who has elevated liver enzymes? Again, what we're going to explain it to you what we know so far. So SARS-CoV-2 and SARS-CoV, which is the first infection which we mostly heard about SARS, shares about 82% of the genome sequence. And even when there's a SARS epidemic that happened early on, 60% of the patients who were getting admitted with SARS-CoV report some form of liver impairment. Also, when I was looking at some papers on Ebola virus, that also about there are a lot of patients, about more than half of the patient coming in very high liver enzymes. And I think since we didn't have that many cases in the US, but there were other places where the Ebola and then causes. And what we have learned, which is the published literature, mostly from China, is that the incidence of elevated liver chemistries on patients who have been getting hospitalized with COVID-19 right now is anywhere between 14 to 53%. So about 14 to 53% of patients will get admitted, are getting admitted with elevated liver enzyme. So what we know right now about from the liver point of view, says SARS-CoV-2 bind to an ACE2 inhibitor receptor to gain entry into the cells. And these ACE2 receptors are not found all over the body, but we also in the prior studies has been found on the liver and biliary epithelial cell. So there has some talk about a direct toxicity of the liver or direct damage of the liver from this virus. And as we talked about, the incidence of elevated liver chemistry in COVID-19 is 14 to 53%. And mostly is AST and ALT elevations, and also there may be elevation of bilirubin. So far, the data has not shown that these patients present with elevated alkaline phosphatase. However, the liver injury is more common the more severe disease you have than the milder cases. So if the more sick you are in the ICU, multi-organ failure, respiratory failure, your liver enzyme would be much higher than patients who have a mild disease. There is a case report of acute liver injury right now with the ALT/AST of greater than 1,000, and there are more reports are coming out. But so far, we have not seen a report of acute liver failure. And if someone sees it, that would be a good case report to publish right away. So severe COVID-19 is uncommon in children. And it is also less likely to be associated with elevated liver enzymes. So I think it's a good point to note that the children may have not have that severe, not only severe COVID, but the liver enzyme may not be that elevated. Also, low serum albumin is a marker of COVID-19 severity. And that's what I think our liver patients are more, we have to pay attention to it. There's not too much histology data that's coming out. There were few studies, but when studies from China where they did has autopsy, when they looked at the histology, it did show moderate microvascular steatosis and some lobular and portal inflammation to focal necrosis. So how does it look on the liver biopsy is still not very clear. And what we don't know about it right now is that whether the elevation of liver enzyme in COVID-19 is because of the direct viral effect, meaning, or there is secondary to other processes, include inflammation, immune response, ischemia, or a lot of patients from China were on different medications that were directly hepatotoxic. So this is the information that we definitely need to look at it and hear more about it. And our patients, the second question that we don't know right now, are patients with chronic liver disease, like your patient with hepatitis B, hepatitis C, fatty liver, are more susceptible to the liver injury. The New England Medical Journal patients paper from China, which is close to 1,000 patients, 12% of them had hepatitis B or hepatitis C, and that did not show to be a significant factor that patients were more chance of dying, but we definitely need more data. And I think that would be a good data in Pakistan, if there is a registry and you can collect it. So what our recommendation is right now, if a patient without any liver disease come in with COVID-19 with elevated liver enzyme. So far, based on what we believe, that we only recommending, at least in the US, and to check for hepatitis B and hepatitis C. We don't need to do any extensive workup beside that. We also recommend avoiding unnecessary imaging, like an ultrasound, because the goal is that these patients does not have too much transport from where they are. Unless you are worried about that you have biliary obstruction and cholangitis, and mostly, so I think it will be a clinical decision, but we are not even recommending that you need to get an ultrasound in these patients. And in America specifically, if the patient had COVID-19 and elevated liver enzyme, there are a lot of investigational or off-label medications which can cause elevated liver enzyme, but we still recommending that if you have these patients should be still considered for these investigational agent. We have a lot of autoimmune patients, but we don't assume that the patients with autoimmune hepatitis or transplant coming in, and you assume that their liver enzyme are just secondary to these flare-up of rejection. If they have COVID-19, please consider COVID-19 in the differential diagnosis. Patients who have, although this is different for children, as we talked about, children does not cause, has severe COVID-19 and does not have significant elevation of liver enzyme. So if a child coming in with COVID-19 and has very high liver enzyme, do not assume that the liver enzyme elevation is all related to COVID-19. That may be a different scenario in the children. However, we do need more data about it, and the recommendation is based on what we know as of right now. So again, now the next sections are what we are just telling that, our colleagues and providers, that if your patient have liver disease or patient have cirrhosis or hepatocellular cancer, how to think about at this time when you have a pandemic of COVID-19. So what we know right now that asymptomatic patient can contribute to SARS-CoV-2 spread, whether you are immunocompetent or immunosuppressed. And children are less likely to be ill, but can still be infectious. So our liver patients will be exposed, and they will be having a risk of getting the SARS-CoV-2. But what we don't know is that if you have a patient with hepatocellular cancer, are they at increased risk of having severe COVID-19? There is data that patients who have other forms of cancer are not at that increased risk of severe COVID-19, but we are waiting for more data to come in. But the second thing also, what we don't know is that when you have a patient with SARS-CoV-2 and patient with chronic liver disease or decompensated or those awaiting transplant, where the outcomes of these patients would be different. There are case reports of patients with cirrhosis and patients with post-transplant 10 years out of it, and they did well and then they survived. So we still need more data about the effect of SARS-CoV-2 in our chronic liver disease, cirrhotic, decompensated patient or patients who are awaiting liver transplant. So, this is a big thing in the US and this is a big push in all over the world right now, that at this time, because of a risk to our patient, we are almost severely limited any outpatient visit. And we only seeing some patients who have urgent issue or clinically significant liver disease. So in our center at UCSF, all of our visits are telemedicine. The only few patients that we are actually seeing in person. We not only have to protect our patients, we have to protect ourselves, our workforce, so we cannot have been exposed. If you're seeing patients, it's good to stagger arrival time, so you don't have 30 to 40 patients waiting for you. You can have few patients with different time slot, and if you have, in the US, we have different exam room, we put the patient in right away rather than have them in the waiting room. We are actually limiting friends or family members who are accompanying their patients, because especially you have to pay attention in Pakistan when they're coming in with a lot of family members, and no one comes into the room or only one person is allowed in the room. In some states where the COVID-19 is not as severe, they are using it. We are using a lot of phone visits or telemedicine. And any patients who are coming to the clinic, they've been getting screened for symptoms of fever or recent exposure before they can enter to the clinic space. If they have any of these symptoms, they're going to go to the COVID clinic in the US. We don't evaluate COVID-19 symptoms and fever in our liver or liver transplant clinic. And I think that should be the case in Pakistan also, because you cannot have them, because patients feel like that your hepatologist or GI specialist is your expert in everything and they wanted to get your opinion. But I think that's the important thing. We also wanted to make sure that your patients or our patients have adequate supply. So we are giving them like 3 months supply of medication, because we don't know if things get worse, the pharmacy can get closed or they would be. So it's very important that your patients will have good supply, especially if they are transplant patient. And in the US, we are suspending most of the program. Not everyone is suspending liver donor liver transplants at this time. And then the disease donor program, which is really big in the US, we also trying to decide whether we need to curtail that or cut down on those transplants. If you have a patient with liver cancer, we consider reviewing imaging for a new referral before the tumor board and before you schedule the patient. Now, the big question is that what about a patient who does not have liver cancer, but you need imaging every 6 months, like hepatitis B or hepatitis C patients, or what happens if they have liver cancer? So it is okay to delay for a couple of months, and but it's an individual decision. But in our centers, UCSF, we are asking patients for delaying for about a couple of months unless they have a very high or aggressive cancer. However, we do consider that hepatocellular cancer treatment is still very essential, and we are proceeding with hepatocellular cancer treatment like chemoembolization, ablations, and radioembolization. However, there are a few patients who have a small cancers. We asking them to wait. It's a very individual decision, but again, it's very important to talk to your patients, because limiting the exposure for any procedure is the key at this time. What about the post-transplant patients? So what we know about the post-transplant patient is that they are increased risk of acquired SARS-CoV-2 infection, especially if they are greater than 60 years of age and because of their immunosuppressed status. However, it is too early to know if immunosuppressed patients are at greater risk of severe COVID-19. The data from prior SARS and MERS epidemic was found out that immunosuppression per se itself was not an increased risk of mortality in these patients. So we had, and there is different theories out there that maybe the immunosuppressed status did not mount that significant inflammatory response, but we still need more data. The data is more from prior SARS and MERS epidemic in the past. However, we do know that if you have immunosuppression, you can have a very prolonged viral shedding. You can give this patient. So when we have these patients in our transplant floor, we are very cautious about it, that because they can shed the virus for a long period of time. Again, if you are in a transplant program, if you have transplant patients where we have a big transplant program, we are actually sending them letter and emphasizing the preventive measure. Although most of the transplant patients should be doing it, but talking about frequent hand washing, cleaning the stuff at home, minimizing sick contact, any travel. So it is a very, very important thing to talk to your patient, because if they get it, they may be may have a more bad outcome than any. Again, we are not seeing any of our post-transplant patients in the clinic. We are talking to them on the phone, adjusting the medication if they need it, or doing more telemedicine. There is no travel. So you have to be very particular for any transplant, post-transplant patient. No matter what transplant they have, they cannot travel right now. And then, in the US, we do talking about that they should not go to work, or because if they are, even the caregiver should get some support from that regard. So that's where the next I want to talk about, if you have patients who are immunosuppressive agent, which is basically if you have post-transplant or someone with autoimmune hepatitis or other condition. So again, what we know is that effect of immunosuppression on COVID-19 is still not well established. However, if we stop or reduce the immunosuppressant, it may cause a flare-up of autoimmune hepatitis or can precipitate an acute rejection. So that's why we have to be very cautious. There is a big debate about whether to use corticosteroid, but WHO right now avoid corticosteroid for the treatment of COVID-19. Unless it's indicated for other therapeutic purposes, like if you're treating asthma, COPD, or other reason, right? So what happens if your patient who are immunosuppression, and which patients do not have COVID-19, without COVID-19? So AASLD, after looking at what we have the data, we are not recommending to reduce the immunosuppression, because there are certain centers or some other places who have these treatment algorithm or guidelines that they are recommending that these patients should be reducing it. So we are recommending against it, because the effect of immunosuppression is not very clear, and then reducing or stopping can cause more problem. However, things are different if you have a patient with COVID-19. So in those patients, we do consider minimizing the dosages if they have very high dose prednisone, like we just started treatment with autoimmune hepatitis, a fresh transplant, but we maintain a dosage to avoid adrenal insufficiency. We recommend reducing, but not completely stopping the immunosuppression, like Prograf or calcium inhibitor, azathioprine, or mycophenolate. But you have to decrease the dose, especially if someone has lymphopenia, fever, or pneumonia, which is attributed to COVID-19. In the US, the other group of patients that we see very significantly is patients with alcoholic hepatitis. But at this time, the question is, if someone you think that need high-dose steroid, you need to look at the potential benefit and the risk associated with it. So if someone has alcoholic hepatitis right now, I have to think about whether starting prednisone and if they have COVID-19 would be worth the effect or not. Also, at the same point, I would say that there is some data from Italy coming about steroid that maybe it may be beneficial in the early stage, but we need to learn more about it. What about the procedures? And I think that's the big debate in the community everywhere in the world. What we know right now is endoscopic procedures should be considered aerosol generating. I know that there's a lot of places, even in the US, there were a lot of debate about it. And we also know data from the China and other countries that there is a fecal oral SARS-CoV-2 transmission. And also the virus is detected in saliva. So every upper endoscopy is considered a very high risk procedure based on this data. Also, 10% of the patients they have some diarrhea, and about 40 to 50% have some kind of an early satiety, or some patients have nausea when they were presented with COVID-19. There's a joint GI societies who recommended that we should consider rescheduling all non-urgent endoscopic procedure. So AASLD and also the government and CMS here also recommended. So we have canceled all elective and non-urgent procedures, including any procedure like a screening colonoscopy or just screening endoscopy for varices, any liver biopsy or fibroscan in the US, we have canceled it. Understanding there can be some procedures that still are urgent, need to be done. Like if I have a patient, I need to rule out rejection, or someone with an autoimmune hepatitis with a very high liver enzyme, may still do a biopsy on that. Patients who require therapeutic paracentesis still need to end up doing it. However, we don't allow them if they have fevers or have symptom of COVID. So it's a good idea to get their symptom before bringing them in or getting the procedure. Although not in Pakistan, but we do tips on a routine basis but only patients who have a variceal bleed, we are doing tips right now. Endoscopy, if someone has variceal bleed, another GI bleed, or very high stigmata with recent bleeding, and we are doing secondary prophylaxis with band ligation. Biliary procedures, if someone has cholangitis or someone has obstruction or myeloma after transplant, these patients these are urgent procedures and still need to be done. However, although I'm not an expert about personal protective equipment right now, there are a lot of guidelines out there. I would recommend that there are 3 good papers outside. And then the one from GI endoscopy by Sutkino is a very good paper talking about the endoscopy and what everyone should be doing. But it's very important that personal protective equipment should be used. In the US, we are allowing our trainees or fellows coming in doing the endoscopy. And there are many reasons behind it. Number one, we don't want them to get exposed. Number two, if they are in the procedure, they are also using a personal protective equipment that can also, we don't have that many of it. So only people who really needed to do it need to be involved on it. Same with if I have a patient with COVID-19, I'm not letting my fellows go see it either. We just give them a recommendation or I go alone. So again, protecting the workforce in the US is also very important, and everywhere else should be the priority. So lastly, I will kind of end about what is the medical management of patients with COVID-19 and the potential drug-drug interaction. Again, this is what we have read about it, and no way we are the expert of COVID-19. We're not the infectious disease expert, but then you may have seen the slide. There are no approved medication or drugs right now. There are investigative or some kind of an investigational drug that has been used everywhere in the world. In the US, there are certain medication. There's just a remdesivir. It's a Gilead compound, which has shown some in vitro activity against the SARS-CoV-2, has also been used in the past for Ebola. There is a randomized controlled trial that has been going on in the US and also available through compassionate use. So that's one of the medication. One is tocilizumab, which is IL-6 receptor blockade. There is a thought that at the end stages of COVID-19, you have a significant cytokine storm. And this medication has been considered or used for it. The important thing to know that both these medications also can cause elevated liver enzyme in a clinical trial right now. The AST and ALT of greater than 5 times the upper limit of normal is an exclusion for our clinical trials. So that's what we know. There's a lot of talk about hydroxychloroquine and azithromycin, and there is a paper from France which was published about 26 patients, I guess, was on hydroxychloroquine, AM, and azithromycin. And the only thing that was shown, it was non-randomized, open label. It was a very small study where they are lost to follow up. And only thing that shows that it did decrease the viral load. There was no clinical outcome that was reported on that clinical trial. So it is a word of caution. I know everyone went on the bandwagon. When I was talking to my ID colleague, there may be a potential, but this is not approved and this may not be the medication. So I just wanted to give a caution, especially if you use both these medications, it can affect the cytochrome P450 system also, and then you have to be cautious about drug-drug interaction. There are some other medication, although favipiravir, which is a flu medication in Japan, is not available in the US, have shown some initial benefit. The one thing is that the no role, there is an antiretroviral HIV medication called lopinavir and ritonavir, which the New England Medical Journal article has shown no benefit. Important thing to know that there is a concern for drug-drug interaction and safety. Hydroxychloroquine, azithromycin, there is a concern about prolonged QT elevation and also some arrhythmias. What we know right now is that the randomized controlled trial of lopinavir and ritonavir, which was published in New England Medical Journal, showed no clinical benefit, no effect on mortality or any decrease in viral load. There were 200 patients on the clinical trial. There are certain centers still using it, but you have to be cautious. These are potent inhibitor of cytochrome P450 system. There was also a lot of debate about the ACE inhibitors or angiotensin receptor blocker. However, the European Society of Cardiology recommends if your patients are on these antihypertensive to continue it. So based on that evidence, our recommendations from AASLD is the evidence does not support the use of lopinavir and ritonavir for COVID-19. Patients who are on chronic ACE inhibitors and ARB should remain on them even in the setting of COVID-19. There is some data from France about this non-steroidal agent, but it's not a clinical evidence is significant. However, at this time, acetaminophen is still a preferred analgesic agent. If you have any patients, although may not available in the United States, but if someone is in an investigational agent, you need to monitor their liver enzyme very, very closely. This is one thing. If you have a patient who have COVID-19 and on different medications, I like this Liverpool Drug Interactions group. We used a lot for hepatitis C, but they have a dedicated page now for COVID-19 drug interaction, not only for immunosuppression for every class of drugs. So, if someone is tried on different medications, I would just say that you can go and review this slide, on the side, and then see if there's any drug interaction with your patients. So in the end, I wanted to make sure that, you can go on to the AASLD COVID-19 Clinical Insight document for further details. This will keep getting updated as soon as we have new information, new studies comes in. We wanted to make it more interactive and in a very lively document. One thing I wanted to definitely see that this is a time that we need more data in our liver patients, in our other patients. So if there is a way in Pakistan that we can have a registry or some way people can contribute to it and learn about it, not only we can learn as a community for our patient, but all the journals, top journals are expediting this. Anything good would be a very publishable, and we would be happy in the US here to review it and help you guide it. So this and I would like to also thank Parsa HealthNet Echo, Pakistan Society of Hepatology and Parsa Trust, and Asad especially, and Zishan, to give me the opportunity to share some of the insight from AASLD. And I'm also wanted to thank AASLD to give me the opportunity to help for my society and further learn about this COVID-19 and liver disease. Thank you, everyone.
Thank you, Bilal. Thank you very much. Bilal, can you stop share, please, so we
Yep,
get
I
back
will
to
do
the
that. Yep.
parents?
Yep.
Thank you. Thank you. Thank you very much. What an excellent talk.